Okay, we may start now, okay?
Perfect.
Okay, first of all, I'd like to thank Dr. Cascone for accepting our invitation to be in our course. Dr. Cascone is the chief of the oral maxillofacial surgery unit at Universidade Sapienza di Roma. Thank you very much, and he gonna talk about the treatment for condylar hyperplasia. Thank you, Dr. Cascone.
Okay, but usually I like to know who is my audience. Can you introduce me your student?
Oh yes, we have now as 20 students. There is our course, arthroscopic GMG arthroscopic course. All of them are oral maxillofacial surgeon here from Brazil, all over Brazil here.
Perfect. So we speak about condylar hyperplasia, and I really would like that you, as you prefer, stop me just to let me to explain you better if you don't understand or if you have any question during my speak. We have a good group of research, very young people or student of medicine and student of dentistry working in the Eastman Hospital that is associated with my university. This is one group, and also there are two senior working too in this group. What we research about temporomandibular joint, most of, and we have a new research of condylar hyperplasia. As you see, condylar hyperplasia in the last 5 years came very involved in publication international of the international research. This is the last few years, so you see how growth the number of publication in PubMed. Can you hear me? Hello? Can you hear me?
Yes, Dr. Cascone, yes.
Okay.
If you have any question, I will ask you.
This is a patient, 14 years old. As you see, I have a fascial asymmetry, malocclusion. The orthopantomography showed that there is an asymmetry of the two condyle, lateral deviation of the midline of the mandible. This is the TC scan. As you see in this patient, there is also a sagittal component, not only transversal. So what to do in this patient? How to treat a patient like this? Still a few years ago, most of the patient with this pathology was treated at the end of growth with sagittal splint osteotomy. Anyway, what we see is that the patient have a condylar hyperplasia with a scintigraphy positive. So we have a correct diagnosis. The diagnosis is transversal, monolateral, condylar, right hyperplasia. What we do now, only condylectomy. We evaluate exactly the amount of condyle to take out, and we do a 3D planning. And this is the patient. This is the patient without any orthodontic appliance, without any other things, only condylectomy. Of course, she needs orthodontics, but she needs orthodontics like every other 14 years old girl that have a small malocclusion. This is an orthopantomography. 2 months later, correction of the facial asymmetry. The patient pre and post. The occlusion pre and post. Other patient, facial asymmetry, completely, this phenotype is completely different from the other one, but the pathology is the same. Condylar hyperplasia. In this case, the condylar hyperplasia was have a vertical component, not a transversal like the other one. And you see the left condyle have an abnormal growth that led overgrowth all the hemimandibular of the left side. Also in this case, we evaluate exactly the amount of discrepancy between the two condyles. This is the TC reconstruction, 3D reconstruction with the evaluation of exactly of the amount of the asymmetry. And what we decided to do in this patient is condylectomy, and was necessary also a remodeling of the mandibular margin. This is the patient of the end of the treatment. As you see, the occlusion doesn't change. And this is the patient pre and post-op. As you see, the patient underwent also orthodontics therapy, and we have a very good interrelationship with our friends orthodontists, and especially in the department in which we work strictly together. And in this way, we can obtain faster results. So these are only 2 cases, but to explain which is our way to understand and to classify and to make a diagnosis and treat the condylar hyperplasia, this is the way. This is a very famous comics actor in Italy, Totò, that have a condylar hyperplasia. This is a very famous dean of the most important newspaper in Italy that have a condylar hyperplasia. So many people have facial asymmetry, and many of these could be could have a diagnosis of condylar hyperplasia, like this one, like this one. And you see, as you see, all these patients have different age, have different phenotype, also completely different phenotype. Anyway, at the moment, the international agreement is on the classification. So, for the truth, there is not still a completely agreement about classification. The old classification was done by Hugo Verghese in 1986. And the last one was done by Nitzan and Wolford in 1988. I'm completely in accord with the classification of Nitzan and Wolford. But anyway, in many countries still is used the Verghese classification. So what Verghese say? There are 3 types of condylar hyperplasia. Type 1, type 2, type 2, and type 3. Type 1 is hemimandibular hypertrophy. and type 2 hemimandibular. Nitzan say, okay, it doesn't matter which is really the etiology of the pathology, but anyway, we can classify the condylar hyperplasia in a vertical growth, in excessive vertical growth, excessive transversal growth, and mixed form. Which the difference between the two type of condylar hyperplasia? So vertical. Look exactly in what there is right here on this side, three-dimensional deformity of the hyperplastic condyle. So the condyle have really a different shape, three-dimensional different shape. The volume increased of the affected side that can involve all the hemimandibular. Usually is absent the lateral deviation of the mandible, or there is an ipsilateral deviation on the same side of the condylar hyperplasia. There is then rotation of the occlusal plane, so the maxilla usually reacts to the condylar hyperplasia, and absence of crossbite. This is vertical. What's about transversal? Transversal is stretching of the affected side. There is a chin deviation. There is a crossbite. There is a deviation of the midline contralateral the side of the condylar hyperplasia. So same pathology, or anyway, in the same classification, two completely different phenotype. Do you have any question?
No.
Hello?
No, we don't have any questions till now. We can continue.
This is just, there is many discussion about this classification, especially in Europe. I think that all over the world now, the classification of Nitzan and Walford is absolutely the way to follow. Diagnosis, how we can arrive to a diagnosis of condylar hyperplasia. First of all, of course, there is the anamnestic, the anamnesis that we can have from the patient, when it appears, how is fast, how was treated before, there is pain or not, there is a contralateral side clicking, or anyway, any other argument that can be involved in this pathology. Imaging. We usually use a standard X-ray, and anyway, standard X-ray is not enough to evaluate a three-dimensional malformation of a condyle. So the best is the TC cone beam, the CT scan cone beam, or anyway a TC scan. But anyway, is the most important things are the scintigraphy, as we see. So, clinical diagnosis, vertical, increase of the volume of the affected side, absence of ipsilateral deviation, and rotation of the occlusal plane. This is for the vertical condylar hyperplasia. As you see, this is a vertical condylar hyperplasia of the left side. As you see, the midline is deviated on the same side. In the transversal, there is a chin deviation, stretching of the affect side, and the deviation of the midline of the mandible, contralateral, as you see here. And usually there is no rotation of the occlusal plane. This is very important just to evaluate later on the therapeutic planning. So traditional X-ray, I don't use more, is absolutely insufficient to evaluate a three-dimensional malformation of the condyle. What we use a cone beam CT scan. With this imaging, you can have a three-dimensional evaluation and also a bidimensional evaluation if it's needed. Bidimensional and three-dimensional. But as we know, the condylar hyperplasia is an active process. So, but how we can say that the process is active? There is a gold standard now in the literature, an agreement that we have to use a SPECT scintigraphy, no more a planar scintigraphy. So there is work of Saridin, and the cutoff, international cutoff agreement is 10% difference or more between the two condyles. And this is the work and this is the work of the Saridin. And she's still working a lot just to look more and more, to be more precise. Also, our group is working on the condylar scintigraphy, and we are evaluating the fact that for the vertical, it could be correct 10%, but for the transversal, we think that more than 7, the difference between the condylar, between the two condylar is enough to say that the condylar is condylar hyperplasia active. We are also studying the patient with the NMR, just to evaluate how is the situation of usually the contralateral side, because most of the time when there is a condylar hyperplasia on one side, the contralateral side is also pushed backward and can have an internal derangement. So we have the classification, we have a diagnosis, now we have to decide how to treat these patients. So there is an agreement, a national agreement, about the necessity of condylectomy in the case of the patient have a active condylar hyperplasia. So how we decide how much condyle take out. Many words in the literature saying minimal condylectomy or a big amount of condylectomy or a proportional condylectomy. I completely agree about the proportional condylectomy. And anyway, I will tell you which is my opinion. Condyle is not important. The most important thing is the correct function between the disc and the condyle. As you see in this patient, this is the insertion of the lateral ligaments, and this is the insertion of the lateral ligament on the contralateral side. So if you look, this patient on this side had this amount of condyle, that is too much. And you can see this also in the position of the coronoid process. You see on the right side, the coronoid process is under the zygomatic arch. On the left side, the coronoid process is in a backward position. These are the measurements that we use for evaluate a proportional condylectomy. And what we do is a proportional condylectomy, but never in one piece. I use a slide condylectomy because I think that we have as much as we can to preserve the anatomy of the condyle. So we have to protect as much as we can the disc and the ligaments and the capsule. So in my opinion, it's too aggressive to take out the condyle in one piece, and I usually do a slide condylectomy. At the end, all the time, I use to stabilize the disc on the lateral pole of the condyle with a micro anchor screw. So, to summarize, how we manage a active condylar hyperplasia in children and in adults. When we do the indication for surgery to a patient, at which age? Do you have any opinion about this?
Yes. Usually in Brazil, we used to treat this kind of...
Can you open the light?
Yeah. Acende a luz.
Okay.
Usually here. Can you hear? Can you hear me?
Yes, I can hear you.
Yeah.
What do you think in the young patient? Do you have any opinion of this still now?
Yes, usually here in Brazil, when we treat adults with condylar hyperplasia, we usually first do the scintigraphy to see if the condylar hyperplasia are active or not. If are not, we just do orthognathic surgery, but if it's active, we usually do a higher condylectomy, just remove about 5 millimeters from the upper part of the condyle. And when we treat with a child, we usually just do the higher condylectomy, and we follow the growth of this child to see if they are at the end of the growth period, we would do orthogenetic or not. Usually we follow this kind of protocol treatment.
Are you used to operate also young people or not? Or do you wait till the end of growth?
Yes, but we just treat the CHMJ. We are not used to do orthognathic surgery before the end of the growth, when they are deal with children.
Okay, so let me go on.
Yeah. It's the same protocol you used to.
Now I will show you what I do.
Okay, yeah.
So, just a moment because my phone is just.
Okay, yeah.
Okay. So, how we deal with active condylar in children and in adults? An international agreement. All we do as you in the same way. We operate the patient with an active condylar hyperplasia as soon as possible. This is a 9-year-old with a vertical condylar hyperplasia. Very easy, the diagnosis, because it's very active. This is a scintigraphy. And as you see, I prefer to cut a big amount of condyle. Can you see how much condyle I took out? Okay.
Yes.
Because in my opinion, the most important thing is not really exact how much condyle you take out, but is to preserve the function between the condyle and the disc. And in this way, if we can do, as you see, this is just few days after operation. You see the asymmetry is still present. This is some years later after the operation, and as you see, the face is obtain a correct symmetry, but the most important thing is the condyle growth in a correct position in the fossa. Can you see it?
Yes.
Good occlusion. And the condyle is in the fossa. Before was scattered here. Because in a young people, if there is a good function, as we absolutely know in the fracture, if there is a good function, the condyle will remodeling in a correct way in the fossa. The most important thing is the correct function with the disc. Pre-op, 1 year post, you see there is asymmetry present 2, 3 years, 9 years, no fascial asymmetry. This is another patient, a young patient, active condylar hyperplasia, right side. This is a vertical condylar hyperplasia. The evaluation of the 3D TC scan. Condylar hyperplasia active. Condylectomy. This is patient. But it's not the same patient. This is the twin. So now we see the real patient. This was the condylectomy. This was the patient 3 days after condylectomy. You can see that the occlusion doesn't change. The asymmetry is still present. 2 weeks later, less asymmetry. A three-dimensional repositioning of the mandible without any big deviation of the occlusion. 3 months later, the occlusion pre, 3 days, 2 weeks, 3 months, no change. And these are the two patients, the twin. And the fascial symmetry become more and more better on the time. What's happened for the adult in condylar hyperplasia for the adult one? There was a very big discussion, and there is still a big discussion between two schools. In these slides are Rudolf Reich, that was the dean of the the leader, one of the leader of the German maxillofacial surgeon on the right side, and Dorit Nitzan, that is, she is my love. I love every time that you speak, because she is really a fantastic researcher. So they think into different way. Dorit say, I can do only in the adult one, I can say only condylectomy. And Rudolph say condylectomy is, there is too much malocclusion for the patient, and a German patient cannot stay with the malocclusion for so long time, which is my experience. I do condylectomy only, also in adult, without orthodontic surgery. This is a patient with transversal, only condylectomy. As you see, most of our patients have the orthodontics during this therapy, because we have a very good interrelationship. For us, it's very easy to work with the orthodontist that works in our department too. Before, after a few months, after 1 year, good facial asymmetry, good occlusion. Could be condylectomy enough for this patient? Or we have to do also a sagittal split osteotomy? Is enough. Only condylectomy. The occlusion was not very good, but we have our friend orthodontist that can correct it easily. Only condylectomy. Vertical, adult, very aggressive. Look at the open bite. Only condylectomy. I think that we finished the time. Can you open the light?
Yes.
Okay. Sometimes, of course, it could be necessary to do also orthodontic surgery, but it's very unusual at the moment. Only condylectomy in active cases, in young patient and in adult patient is enough. And next time that you want that I speak with you, I can say that also in adult patient with no active condylar hyperplasia could be enough only condylectomy. Because if it's enough in active case, why cannot be enough in a condylar hyperplasia also that is not active? So my opinion is condylectomy is the main choice that we can do for this kind of patient, and utilize orthodontic surgery only in few cases in which there is a deviation of the maxillary plane more than 5 millimeters, or there is a sagittal component of the protrusion of the mandible that cannot be corrected only with condylectomy. That's all.
Okay. Thank you very much, Dr. Cascone, for your great lecture. Maybe we have some discussion here, because a little bit I think a little bit different from what the way we deal with this kind of problem here in Brazil. And let me see if I understand. Do you always do condylectomy even when the scintigraphy shows you that is not active, the condylar hyperplasia? Is it correct in adults?
Yes, the problem is you have to do the diagnosis of condylar hyperplasia. Sometimes it's very clear. Sometimes you have a condylar hyperplasia, very clear condylar hyperplasia. Anyway, you do a scintigraphy, and the scintigraphy is 5%, 6%, no active. That, in my opinion, does matter. If you can correct this asymmetry only with condylectomy, why don't you do it? It's much more easy than a sagittal splintostomy. You can correct exactly the pathology at the beginning. You have not the problem that the condylar hyperplasia can grow again during time. So why don't you do only condylectomy?
Yes, it's interesting because it's different from the protocol we used to follow here in Brazil. That's similar to Dr. Wolfer protocol. That's you only do the condylectomy and just a higher condylectomy when you have a active hyperplasia, condylar hyperplasia.
This is very easy. This is very easy. Of course, when you have an active, you do condylectomy.
Yes. But
you have to tell me, why don't you do, if you have a diagnosis of condylar hyperplasia? Okay, the problem is, when you have a diagnosis of condylar hyperplasia, could be active or non-active. Why, if you can correct the active form, why you cannot correct the inactive form?
Yeah. Yes,
you don't do any damage of the condyle. When you do a condylectomy, if you do a slight condylectomy, very safe, if you preserve the lateral ligaments, if you don't touch the disc, why don't you do condylectomy?
Yes, it's very interesting because here the orthogenetic surgery is much more popular here than the CMJ surgery. That's why we used to treat. Yeah, yes,
That's all over the world, not only in Brazil.
Yeah. And also in United States, I think so. That's why we treat in this kind of. We usually do the orthogenetic surgery, just do the CMJ surgery when we have the activity problem in the condylar hyperplasia.
This is correct.
This
is absolutely correct.
Okay. I will open now to see if we have more questions from the audience. Any questions? Okay. Yes. Yes. We have a question here. If you have a minimal age to operate a child that have an active condylar hyperplasia.
What do you say? If I operate a child?
Yes, and do you have a minimal age?
As I do the diagnosis, I operate. It doesn't matter. More younger the patient, easier the operation.
Okay, even if you have 4 or 5 years old?
Of course.
Okay, yeah. Any more questions? Acho que proporcional que ele falou.
The anatomy of I'm very used to operate very young patients because I have a very important department of pediatrics in my university. So I'm used to operate ankylosis in 1 year, or Piero sequelae at 5 days and 10 days. So the anatomy of the young people is easier, and the patient can react much better than an adult patient.
Yes, it's very similar the protocol used to do here in Brazil, because when you have when you operate a child, the follow-ups is very good, and the occlusion is getting better with time. And it's very similar. We have another question. Do you always do what kind of condylectomy you used to do in adult patients? Do you remove 5 millimeters? Do you have a proportional? Do you have a what kind of?
I usually do a proportional, but
yeah.
anyway, I evaluate this with a TC scan. I do a slide condylectomy. That, in my opinion, one of the most important things, a slide condylectomy, not the condyle in one piece. And I every time check the occlusion, and I prefer 1 or 2 millimeters more than 1 or 2 millimeters less.
Yes. And there's any case that you used to reconstruct the TMJ, like doing a graft or a prosthesis?
In this kind of patient, never, absolutely never.
Even if you have a tumor like osteochondroma in the TMJ, you never do any reconstruction?
No, but it depends. It depends of the kind of tumors, of course, and the entity of tumors. If I have to resect all the condyle till the sigmoid notch, so condyle and neck of the condyle could be necessary TMJ reconstruction, and I usually use a TMJ concept prosthesis custom made.
Ok, yeah. Mais alguma pergunta? Eu vou no final. Mais alguma pergunta? Fala, Lu. We have another question that is, you told us that's very important to maintain the relation from the condyle and the disc, but you remove the condyle. How you do this? You maintain this kind of a relation between the condyle and the disc?
Fantastic question. I'm very happy that you have done. So, what's the problem? The problem is not the condyle, is the disc. If you put the disc on the neck of the condyle will become the head of the condyle. And if you open again there, you will find the cartilage. Because most probably the temporomandibular joint is a pseudoarthrosis, so it's remodeling continuously with a function. So what I do is to cut out the condyle and to fix the disc top to the neck of the condyle, to the part of the mandible that remain. And if you do a TC scan, like I show you in one of the slides before, you will see that the condyle remodeling and become, the neck of the condyle will become the head of the condyle in the fossa. Do you understand me?
Yes. And okay.
Can I share with you one of the most important problem of this pathology?
For sure, yes.
That I have had in Italy, that I think most of us have all over the world, is to convince the orthodontist that when they saw an asymmetry, when they correct a lateral deviation of the mandible and the patient relapse after 6 months, they must have in mind that could be a condylar hyperplasia. Otherwise, what's happened is that the orthodontists follow the occlusion all the time, and the patient will have a root resorption or a malocclusion for all the life.
Okay, and if the disc is not viable when you do the surgery?
I don't understand.
And then if the disc is not okay?
Pardon? I didn't understand.
If you, when you do the reposition of the disc after you do the condylectomy, and if you see in the surgery that the disc is not okay to maintain this disc, have a perforation, what did you remove the disc?
No, I never. For me to take out the disc, in my opinion, is to kill the temporomandibular joint. So I never do. It's very, very unusual that I remove the disc for any situation. Also, in the most important temporomandibular disorders, I try every time to reduce the disc in a good position, to freeze it anteriorly, and to stitch if there is a perforation, as much as I can. Of course, in
Okay.
few cases I cannot do, but I never, for me, it's to kill the temporomandibular joint, to cut the disc. And
to fix the disc, you use an anchor or a screw?
Yes, most of the time, yes. With an anchor screw, I hold the disc with the lateral ligaments, and I hold the lateral ligaments on the lateral pole of the disc, of the condyle.
Okay. We have another question. How the other CMJ used to how is the other CMJ does not operate? How is it works?
This is a good question too. Just a few days ago, I was speaking with Larry Wolford, and he told me no one evaluate the contralateral temporomandibular joint. And I told him, no, you are evaluating because I know that you are working on it, and me too. We are just working to evaluate with the NMR the temporomandibular joint on the opposite side, because of course, the phenotype of these two different condylar hyperplasia, the vertical and the transversal, could have also a different etiology. And it could be one option is that the transversal condylar hyperplasia could be, the etiology could be a less working contralateral side. So one side works less, the other side works more. Could be, but at the moment, no one knows for sure.
You're going to bring the answer next time. Another question, Dr. Cascone. How you do the physiotherapy treatment after the surgery?
Pardon, how I do what?
Physiotherapy treatment.
Yes, it's important, the physiotherapy for two reasons. First of all, you have to check as a surgeon that the temporomandibular joint move in a correct way. So it's very important to check the patient and let the temporomandibular joint move correctly in the young patient and in adult patient. So you can do by yourself, the patient can do by himself, or you can need, if you have a good physiotherapist that works strictly with you, is a good option. Anyway, also the three-dimensional repositioning of the mandible could be achieved by position of the hand on the chin. I say to the patient to close the open bite in this way most of the time. They have to do with the hands, but we are very lucky for our orthodontists. So our orthodontists move the mandible with elastics and allow the mandible, the 3D repositioning of the mandible soon that without any orthodontist.
Okay.